Welcome back. Today we'll be discussing our final topic in the 2T echocardiographic assessment of cardiac disorders. Broad heading of the approach to chronic shortness of breath. This will be a discussion on the assessment of pulmonary hemodynamics using to do 2D echocardiography. So again, the basic premise remains the same. What do we measure using ultrasound? We measure the size of structures, the velocities of tissues or of blood, and using these parameters we can actually assess the change in these measurements between diastole and systole. The movement of tissues can be used as a circuit marker of myocardial contraction and relaxation, and pressure gradients can be calculated using the velocity of blood using the simplified modified Bernoulli equation. From our previous discussion, I had highlighted that there is view called the high parasternal short axis view. So this passes through the RV inflow, the RV outflow, and the aortic valve, and produces the characteristic Mercedes-Benz appearance. And now, just to highlight the flow, the direction of blood flow, it goes from the RA into the RV, and then from the RV into the pulmonary artery. Okay, obviously in different phases of the cardiac cycle. And essentially the RA, RV, and the pulmonary artery are wrapped around the root of the aorta, and this is the aorta at the level of the sinuses of Valsalva. And behind here we've got our left atrium. Get down to the assessment of pulmonary hemodynamics. So when I say we're going to discuss pulmonary hemodynamics, first we'll be using measures of dimension, and here we use absolute values. The absolute values will obviously be measured using M mode and B mode ultrasound based techniques. So the main pulmonary artery diameter is assessed. Now the main pulmonary artery diameter is assessed at a point in the high parasternal short axis view that is distal to the pulmonic valve. So this would be the pulmonic valve, and proximal to the bifurcation. So this is the bifurcation. So that is why it is being measured at this point. Okay. The cutoff typically used is 25 millimeters. We'll discuss later that in CT we use a cutoff of more than 29 millimeters. Okay. This cutoff therefore has higher sensitivity. Specificity is significantly low. On the other hand, a very recent study has demonstrated that the main parameter that determines the expected diameter of the main pulmonary artery is actually the height of the patient. So it needs to be standardized for height. The diastolic diameter should be more than 50 millimeter per meter of height, and systolic diameter should be 19 millimeter per meter of height. So this would mean that the expected diastolic diameter would be equal to, say a person is 1.8 centimeters, would 1.180 centimeters is 1.8 meters into R 90. So it should be more than this for me to say that the patient has got a dilated pulmonary artery. Okay, that's how we calculate it. Now moving on, we use pulse wave and or continuous wave Doppler assessment to estimate the pulmonary artery hemodynamics. Okay, so there are two things that we can measure. One is obviously the pulmonary artery pressures themselves. The second is you can get an estimate of the pulmonary artery vascular resistance. So these are the two things, and these are what constitute assessment of the hemodynamics of the pulmonary vasculature. Pulmonary artery systolic pressures can obviously be systolic. Systolic we have already measured. We know how to measure using the tricuspid regurgitation max velocity. Okay, please see the previous echocardiographic video if you have a doubt regarding this. Diastolic, we will see how we measure it, and then we'll talk about the different ways of measuring mean pulmonary artery pressure. And notably, it is the mean pulmonary artery pressure that is used to estimate the pulmonary vascular resistance. Okay, so we need to get to the mean pressure in order to calculate the pulmonary vascular resistance. Okay, so the diastolic pressure can only be measured if the patient has a pulmonary regurgitant jet. So there is no pulmonary regurgitation, I can't measure the directly measure the pulmonary diastolic pressure. So if there is regurgitant jet, what we've done here is essentially we've taken the RVOT view and we placed a cursor passing through it, and the regurgitant jet is going towards the probe. So this is the regurgitant jet. Okay, and what we've done is we've taken their peak velocity of regurgitation. So say for example this is the peak velocity of regurgitation. From the peak velocity of regurgitation, using the modified Bernoulli equation, it 4 into the PR max velocity, the whole squared, would be equal to your the diastolic pulmonary artery pressure. Okay, now we'll talk about how to determine the mean pulmonary artery pressure. So the first way is when you don't have a no TR jet, no TR and no PR. So there's no pulmonary regurgitation, there's no tricuspid regurgitation. In that situation, we use something known as the pulmonary artery acceleration time, which is something we'll get into eventually. So how do we do that? So that is just equal to estimated using a regression formula. So the regression formula has a y-intercept and a slope. So y and s. So what is that y? Y, the simplest formula uses a y of 80 and a slope of minus 0.5. So the equation becomes is equal to 80 minus 0.5 or half into the pulmonary artery acceleration time in milliseconds. So this will be our mean pulmonary artery pressure as estimated using this regression formula. There are two other regression formulas and we'll get to that in a while. So the next thing is the pulmonary artery systolic pressure. Okay, so this is the pulmonary artery systolic pressure. So the pulmonary artery systolic pressure is again related to the mean pulmonary artery pressure using a regression formula. So the PSP is PSP into 0.61 plus 2. Okay, that is your PASP. So to assess the PASP or to assess the pulmonary artery systolic pressure, we will need a TR. So here we need a TR. Without a tricuspid regurgitation, remember, we cannot do this. Okay, the last thing is we can assess it like we assess mean systemic blood pressure using the pulmonary artery systolic pressure and the diastolic pressure, and predictably this is the equation. So it is 1/3 of the pulmonary artery systolic pressure plus 2/3 of the pulmonary artery diastolic pressure. So this would be assessed via 4 into PR max velocity, the whole squared, and this would be assessed using the TR max velocity, the whole squared, 4 into this. Okay, so from this we can estimate the mean pulmonary artery pressure. Okay, pulmonary vascular resistance assessment. So this is known as the estimated PVR. This is very important. It is the estimated PVR, which is very different from the measured PVR that we get from right heart catheterization, and we'll see why this is not as reliable as that and therefore is not that useful clinically. Now, actually it cannot be assessed based on pulmonary artery acceleration time, but it can be, you can get an idea. It doesn't give you a hard value, but it does give you an idea about increased PVR. That is your pulmonary artery acceleration time can tell you about increased PVR. The other thing is you can actually measure it by estimating your pulmonary vascular resistance using either a regression formula or Ohm's law, and we'll come to that subsequently. So this allows you to actually quantify. But the thing is that this quantification is not as reliable and is not reliable enough to be used clinically in under most circumstances. So this is a slight problem. Okay. Now in pulmonary artery acceleration time, before we understand what is pulmonary artery acceleration time, we just need to go back to our basic pressure volume curve that we had discussed. See, you would have noticed that even when I was talking about the right ventricle, I have often labeled the x-axis as LV volume. This is because the general principles are the same. Okay. However, this particular diagram is actually the LV pressure volume curve. It is not the real RV pressure volume curve. The RV pressure volume curves looks slightly different. So what does it look like? It looks like this. So as you can see, obviously the RV mass, the pressures that it reaches are much lower than that in the LV. Okay, even this is not to scale. Otherwise, the graph is very similar. Because of that, the thing is that this was the slope. The slope was equal to obviously the delta, because this is P and this is V, volume. So this was the delta P by delta V, which is actually what is known as the elastance of the ventricle. So this is the elastance value. Okay, so essentially otherwise the curve is exactly the same, but why I discussed this right till now, not discuss this because I didn't want to cause confusion. Now we'll assess situations in which the afterload on the right ventricle is changed. So when the afterload on the right ventricle is changed, the actual curve needs to be assessed. Why am I saying that? Basically, the pulmonary artery pressure determines the volume at which the pulmonic valve closes. So whether it closes at this volume or it closes at this volume or it closes at this volume is determined by how high the pulmonary artery pressure is. So the pulmonary artery pressure times the pulmonary artery elastance is what determines it, and the pulmonary artery elastance is actually this line. So wherever these two lines intersect, that is where the pressure becomes in the pulmonary artery starts to exceed the pressure within the right ventricle, and that is when the valve therefore closes. If, for example, the pulmonary artery pressure was to have increased, so as you can see, what happens is now the pulmonary artery pressure has increased because the pulmonary artery compliance has decreased, and this is what happens with pulmonary artery hypertension. So because the compliance of the RV has decreased, the slope has now become steeper. Now because the slope has become steeper, now it intersects the RV elastance line at a slightly more upwards and rightward point, this point. Okay, so because of that, we end up coming up with this. This is what happens to the curve. The curve gets shifted completely to the right and upwards. Now, so what do you see? You see that the pulmonic valve is actually closing at a higher RV end systolic volume than expected. So this is the end systolic volume and this is higher than expected. So why is this important? So it is closing at a higher end systolic volume than expected, and this is the end systolic volume. So why would this be important? This is important because if the end systolic volume is higher and the end diastolic volume is not that significantly increased, which it is not, what happens is that the curve becomes narrower. Okay, therefore the gap here, or the stroke volume, has actually decreased. So now the thing is that obviously the stroke volume of the left side of the heart and the right side of the heart have to be the same. Now what happens is that because there is increased volume here by a Frank-Starling mechanism, the ventricle starts to contract a little bit harder. Now when the right ventricle starts to contract a little bit harder, as you can see, the curve, instead of being a symmetric curve, okay, is getting skewed a little bit towards the right. Okay, so there's a slight pull towards this side. This is not really what happens in the pressure volume curve, but I've just shown this for purposes of better understanding. But as you can imagine, when the ventricular contractility increases, the rate at which flow occurs during the early parts of systole becomes faster. Okay, so what am I trying to say? So we placed a probe in the parasternal short axis view, high parasternal short axis view. This is the line of interest. Flow away from the probe would be negative and flow towards the probe would be positive. So during, obviously, pulmonary ejection flows from the right ventricle to the pulmonary artery. So because of that, what happens is there is a negative flow, and this is the slope. So this slope is actually the dV by dt, or the acceleration. So what happens if the afterload is increased or the pulmonary artery pressure increases? So once the pulmonary artery pressure increases, as we saw in the previous graph on the pressure volume curve, what happens is that the end diastolic volume is higher and the end systolic volume is also higher, but the gap between them has decreased. Okay, so because the end diastolic volume is higher, the ventricle is stretched more, and by Frank-Starling mechanism, the ventricle therefore contracts in a more strong way. as a result, what happens is that in order to maintain constant stroke volume of the right ventricle, the right ventricle is forced to accelerate the blood much faster. Therefore, the slope actually becomes steeper. So as you can see, from this slope, it has gone to this slope. So as a result, the peak is reached at from the onset of the ejection to the peak, the time decreases. Okay. So what does that mean? That vaguely pulmonary artery pressures are inversely related to the pulmonary artery acceleration time. So I can actually estimate that. But why is the pressure increase? Because there is an increase in pulmonary vascular resistance. Pulmonary artery acceleration time is 125 plus or minus 25 milliseconds. This is the norm. So if it is decreased by 50, that is, it is particularly if it is less than 50, that is, if it is 75 plus or minus 25 milliseconds, then we can be pretty sure that there is increased PVR. Now, I know this is a semi-quantitative, almost qualitative measure, but it is the only reliable echo way method for assessing the pulmonary vascular resistance. Okay, the other methods that we're going to come to are based on a lot of assumptions, and those assumptions are not really always valid, and they result in very varying values or more often than not. So like I said, you can use the pulmonary artery acceleration time to estimate the pulmonary artery pressure, and we had seen the equation was 80 minus half of the acceleration time. But there are two other equations that can be used depending on the absolute value of the pulmonary artery acceleration type. If it is more than 120, more than equal to 120, then we use this formula, that is 79 minus 0.45 into the acceleration time. And if it is less than 120, then we use 90 minus 0.62 into the acceleration time. So these are both regression formulas. Okay, that is how the relationship is. However, this is for estimation of the mean pulmonary artery pressure, not the pulmonary vascular resistance. So a reduction in the reduced pulmonary acceleration time does correlate with a increased pulmonary vascular resistance, but it does not give you an actual quantitative value. Okay. If we want to go in for a quantitative value, we need to use the pulmonary artery systolic velocity time integral. Now, if you remember from our discussion on the systolic assessment of systolic function of the left ventricle, the velocity time integral was what? It was just the velocity times the smallest possible change in time, the whole integrated over a span of time. Say this is the ejection curve, it is the area under this curve, and essentially this was the length of the cylinder that we were ejecting into the aorta. And if the LVOT diameter was the area into length would give you the volume of the cylinder. As a result, giving you an idea about the stroke volume, or allowing you to calculate the stroke volume. The same principle applies here. Here also we can assess the RV, stroke volume, and if we multiply that stroke volume by heart rate, we get a cardiac output. We can add the easiest way, or the simplest, most intuitive way would be to use our hydraulic estimation of Ohm's law. That is, we can estimate the pulmonary vascular resistance as the difference between the mean pulmonary artery pressure minus the pulmonary capillary wedge pressure divided by cardiac output. So we already know there are three equations for estimation of the pulmonary artery mean pulmonary artery pressure. So I could either do it using the acceleration time, or I could do it using the pulmonary artery systolic pressure, provided we have a TR, a tricuspid regurgitation rate. I hope that is clear. Or I could even do it using the pulmonary artery systolic and diastolic pressures, provided I have both a tricuspid regurgitation and a pulmonary regurgitation. Then we can estimate the pulmonary capillary wedge pressure. So this is approximately equal to the left atrial pressure, and we know that the left atrial pressure in all situations except in constrictive pericarditis is directly proportional to the E by E prime velocity that we had talked about during our discussion on the LV diastolic function. That plus 4 gives you the numerical value for your pulmonary capillary wedge pressure, and the cardiac output, as I've just discussed, is equal to the area of the RVOT, area of the RV outflow tract. So this is the radius of the RV outflow tract. Then the velocity type integral, which is basically the length of the length of cylinder that we are ejecting into the pulmonary artery. And finally we have our heart rate, which will give you the cardiac output. Okay, so this is your hydraulic analogy for Ohm's law. But as you can see, the issue here is that we are using one regression formula, another regression formula, and we are using a velocity. Okay, the cardiac output assessment is essentially accurate. However, the heart rate varies over a period of time. So 3 gross simplifications of the actual listing. So the value of the pulmonary vascular resistance that we get from this can often be very unreliable. Definitely doesn't correlate exactly with what we would get on right heart catheterization. Okay, the other option is to use a regression formula, which is if there is a tricuspid regurgitant peak velocity, instead of converting that into pulmonary artery systolic pressure, we just directly use the velocity and divide it by the velocity time integral. Okay, so this is a surrogate marker of the pressure gradient, and this is a surrogate marker of the flow. So this is a pure regression formula, nothing else. It is just based on regression analysis. Okay, so this is the other method by which we can do it. Both methods give you an estimated pulmonary vascular resistance. This is not a very reliable method, and PVR should ideally be estimated using our right heart catheterization. But as we know, it is very difficult to do right heart catheterization. It has a lot of antecedent problems related to the procedure, and is done only in specialized centers. So this is the best we have. Okay, so since the best we have is not very useful, instead what we use is actually we use our HRCT, okay, as a stand-in. So the HRCT has some very specific signs. So if those are positive, that is a high positive predictive value for pulmonary hypertension. So we'll be discussing this on our discussion on the imaging in pulmonary artery hypertension. So I'll go into the details then. I hope I've given a convincing argument against the use of estimated pulmonary vascular resistance in routine clinical practice. Okay, so thank you, and I'll see you next time.